venography is certainly the gold standard. You may see easily what is a normal jugular vein in healthy control, and what means CCSVI. This is the ruin of the jugular vein. You may see stenosis and collateral circulation as shown in the cartoon in the movie. What we may say about the diagnosis? Catheter venography, no doubt, is the gold standard in medicine. MRV was used to try to demonstrate CCSVI, but MRV has very low diagnostic accuracy. This has been demonstrated recently in a paper published by Oinaki on the International Angiology, because MRV have a good accuracy in measuring the cross-sectional area, but is not capable to detect intraluminal septa, valve malformation, and membranous obstruction, that are the majority of the cause of obstruction. Avigos cannot be studied due to the movement of the heart. Color Doppler is a first diagnostic step in venous truncular malformation. It is a level A recommendation of a UAP consensus document published last December. Color Doppler gives indirect information of the Avigos hemodynamics, as well morphological and hemodynamic information on the outflow through the internal jugular veins. In trained operators, Color Doppler showed the satisfactory reproducibility, 0.8K coefficient. You may see by high-resolution venography a normal valve above that can be easily seen, opening and closure, and you may see a valve malformation, a septum, that cannot be crossed by the blood flow. So this is very clear. It's a non-invasive screening by using our methodology. Regarding treatment, percutaneous transluminal angioplasty, PTA, was the only published technique, and please refer just to what is published, not to blog of patients. PTA was demonstrated to be safe. Stenting was never used. In consequence of the high risk of migration, we do not have currently a lack of knowledge of the fate of metallic stent implanted in long term in the venous wall in people with lifelong expectancy, like young people affected by MS, and for the lack of dedicated material. So we do not recommend to use stenting procedure. PTA in the jugular vein showed high rate of restenosis from 29 to 47%, but in the Avigos did not. However, PTA can be safely repeated, and they are recommended to use this with respect to the stenting procedure. Influence on PTA on MS outcome in the Juvenile vascular surgery study cited by Dr. Miller. Significant reduction of relapses, significant reduction of active lesion, improved multiple sclerosis functional composite, improved quality of life also in secondary progressive and primary progressive people, significant decrease in chronic fatigue, and probably chronic fatigue is the symptom of CCSVI. This study, of course, is a pilot study and presents shortcoming, absence of control group, and of blinded assessment. This is certainly not a rigorous study. We need of this in order to plan randomized control study based on the results of this pilot study. We also designed a pilot study together with the Buffalo group that is called Endovascular Treatment Multiple Sclerosis Study. We divided our patient population in two groups. The first group underwent to immediate treatment, is immediate endovascular treatment group, and the second group, delayed endovascular treatment group, was operated on 6 months later. So for 6 months, we take the opportunity to measure clinical and MRI outcome with very rigorous protocol, and this is under the way of publication. We know just vascular outcome. Treatment also in this group with endovascular angioplasty was safe and well tolerated. Rate of restenosis was decreased with respect to the first study, 0% in the avigus, 29% in the internal jugular vein. Endovascular treatment MS study evaluated clinical outcome measure, MRI conventional and non-conventional measure, including longitudinal data on iron deposition. Complete statistical analysis is underway by an independent statistician, and we plan to present this at the next ACTRIMS meeting. Perspectives. These are some perspectives in our center. From the point of view of the basic sciences, we are creating a model of endothelial cells modification at the transcriptional level, modulated by the known and measured hemodynamic stimuli. From the point of view of epidemiology, we are planning together with the Italian Association of MS a blinded studies on CCSVI prevalence in our country. Genetics. We investigated mutation in genes involved in venous apparatus development in a locus related to multiple sclerosis susceptibility. This pilot study is in press, but is under embargo, and we reveal the results, very interesting from my point of view, next month. Pathology of venous malformation, including morphology and proteomics, are under the way of publication together with the Genève group. Pathophysiology, including advanced MRI and non-conventional techniques, are working group together with Robert Zivadino and Binek. And treatment. We are planning together with the Italian MS Association a rigorous randomized control trial to compare RR with and without the additional tool of angioplasty. Thank you for your attention.
Dr. Zamboni, thank you very much for sharing that valuable information. Maybe you could just kind of summarize what you can conclude from the research that you've completed so far, speaking to what you believe researchers could build on your work and the need to learn. What more do we need to learn in order to determine what the suggested relationship between CCSVI and the disease process in MS?
Yes, this is really a work in progress. We